Okay, everyone watch the video okay? I hope. Hopefully I saw at least 26 views on there. I haven't looked, I haven't checked my analytics yet. But, so any questions from the PEDS section? Everyone feel comfortable with the dosage calculations-ish? It's just, it's funny because, like, even, like, going into, like, your clinical year, like this is kind of like bread and butter type stuff, like being able to calculate concentrations and figure out the dose, how many mLs to give. And a lot of people just don't like practice it very often. And so that's why I try to like get you started like now, and then like we'll cover it again when we get to the PED section, like pharmacology, and try to at least get you guys like comfortable and familiar with it. So that way when you're out there in the real world and clinical practice, you guys can look like rock stars to your preceptors and be like, oh yeah, I already know how much to give this. I know how much I'm going to go ahead and do this many mLs twice a day. And they're going to be like, wow, I didn't even know that. So that's kind of the goal there. It's not just trying to be mean to you guys to make you do math you don't want to do otherwise. So anywho, all right, so let's go ahead and move on. I'm going to try to get these next two sections done now, so that way we can just have review for the last class session, right? Is everyone okay with that? So if I don't finish, I'll post a video with the rest of this. Is that okay? Everyone's comfortable with that? All right, good. People usually like the reviews. So briefly, we're going to go over therapeutic drug monitoring. We're going to see what that means. Do you guys remember what it means when I said therapeutic drug monitoring? Basically, we're monitoring drugs therapeutically, some might say, right? Yeah, so basically that's one way to say it. The other way to say it would be we're measuring plasma levels of these drugs and seeing, based on those levels, how we should be changing the dose, right? So we'll find that different drugs have different ranges which are appropriate based on efficacy, based on toxicity. And so by shooting for certain ranges, we can make sure we keep our patient therapeutic without making them toxic, okay? So that's the kind of the goal there, blood levels. So as you remember, looking at our levels here, there's peaks and troughs, right? So the peak occurs shortly after we give the medication, right? Obviously, the time to peak can depend on if we're giving the drug orally. Obviously, that'll take longer than if we were to give it, say, like IV, we'd have a very kind of rapid time to peak. And then as the drug gets metabolized in the body, you're going to notice that eventually you're going to get to this trough period. And the trough is right before what? Well, right before the next dose, right? So drug will get down to whatever trough. In some cases, maybe 0, depending on how frequent or infrequent you're giving the drug. But we'll give another dose at this point, right? So watching this, if you were just to see the single dose being given, how it would get metabolized, we're going to dose it before then because we don't want it to get down to that point. We're going to dose again, and this will hop the peak back up, right? And so based on if you're doing a consistent dosing, say you're giving a drug every 12 hours, after about 4 to 5 half-lives, you should be at that steady state, right? And so based on that, we should be able to say, okay, this is pretty much how the patient's handling the drug. Let's see where the level's at to see if it's going to be appropriate or not. And so it's going to be important because if you're looking at, especially with things that have like a narrow therapeutic index, we'll talk about that again, but basically, if you get the peaks too high, that can lead to possible toxicity, right? So we have to make sure we're not giving the patient too much drug. And then in some cases, you want to make sure you don't get too low. So in the case of like antibiotic activity, you're going to find there's certain drugs you want to make sure you have above a certain level, because once you get below this kind of specified level, you can see that the bacteria start to reproduce, right? And we don't want that to happen. We want to make sure we're killing off this bacteria. And so that's when we'll go ahead and make sure we're dosing again to make sure our troughs don't dip too low, right? So that would make the drug ineffective if they dip too low. So again, it can be very case dependent depending on the drug you're dealing with. And essentially what it should look like is that when you're giving a drug very consistently, you should see very kind of orderly peaks and troughs. And assuming the patient's handling the drug consistently, no matter when you check that patient, say a week down the road, they should still be maintaining pretty much the similar peaks and troughs, right? Obviously, patients change over time, especially if they're critically ill, so you can see differences in their ability to absorb the drug, or you can see changes in clearance of the drug, and that can all affect your dosing, and that's why we check these levels. Okay. So, and again, you can keep the same average steady state concentration. You can give a drug very infrequently at a bigger dose, or you can give the drug more frequently at a smaller dose, right? The same average steady state concentration is going to be the same here. And just kind of like that quiz question last time, hopefully all of you got it right. By giving a drug less frequently but at a bigger dose, you run the risk of what? Toxicity, right? And then also possibly low efficacy, right? So if I drop down too low, you may be able to see where the drug becomes ineffective, and that's not good, right? So that's one reason why we might give a drug more frequently at a smaller dose. So you guys familiar with the drug penicillin? Everyone's heard of it. That's an example of that, where if you get too low, bacteria like to reproduce. If you get too high, you see toxicity. That's not one we normally do therapeutic drug monitoring on, but it kind of illustrates that point of why we dose it the way we dose it, which is usually every 8 hours, every 6 hours, somewhat relatively frequently. But And again, about 4 to 5 half-lives is going to take us to get to that steady state. And again, based on consistent administration, consistent dose that we're giving, you shouldn't be able to achieve that steady state level, and should stay pretty consistent no matter, as long as the patient does not have any changes in their bioavailability or changes in clearance of that drug. So again, this clinical pharmacokinetics, this is an application of these principles we've kind of learned all about to make sure we have safe and effective management of those drugs for individual patients. And then we make sure that the magnitudes of those responses are not going to lead to toxicity, but they remain pretty effective. And so that therapeutic drug monitoring more specifically is going to be using serum drug concentrations. So we're going to draw blood off the patient, isolate out the drug, and figure out what the concentration is, and using those principles to try to figure out, okay, what's the best way to treat this patient? Should I give them a bigger dose less frequently? Should I give them a smaller dose more frequently? How should I do that? And then it's really important to understand the merits, the limitations, and applications, right? Because if you're using it inappropriately, it can be very expensive and you're drawing too much blood. If you're using it inappropriately on the other side, maybe not checking levels enough, you may lead to potential, either you don't eradicate the infection, the patient continues to get sicker, or they get sicker from the actual drug you're giving because it's too much. So, you know, and again, early definitions of the therapeutic drug monitoring is you know, try to maintain those drug concentrations within that therapeutic range. And we'll talk about certain drugs where we're going to look at the range and see what is most appropriate based on kind of the studies we've done to figure out, you know, what's the best dose for those patients, what's the range where they're going to most likely be therapeutic without being toxic. So again, therapeutic range just refers to that dosage range or blood plasma concentration we're expected to achieve the desired results. And so again, when you have a longer, kind of a more, you know, a wider therapeutic range, you have a larger ratio between something like the toxic dose 50 and the ED 50, you don't really need to do a lot of therapeutic drug monitoring, because it'd be very difficult to get up to a point where you're actually causing a lot of toxicity given the dose that most patients are going to be effective at. But it's going to be these drugs that are going to be much more narrow to where you want to make sure that, yeah, I can give them a dose where I can be pretty sure I'm going to eradicate that bacterial infection, but if the dose is so high that I end up causing nephrotoxicity, or I may cause ototoxicity, and now the patient can't hear anything, that's a problem, right? So now you've kind of traded one problem for another. Again, this would be an example of something that can have a wide therapeutic index, but note that the slope can be pretty steep, to where once you kind of hit that critical point, you can start to see that even small changes in dose can lead to big changes in either the efficacy or the toxicity. And so those are the kind of drugs we're going to be more likely to do therapeutic drug monitoring on when it's kind of, there's more patient variability, or there's just a high risk for having more toxic effects. Here's something with a much more narrow therapeutic index. You can see here that at that point where you start to get, say, 85–90% of people responding, you're already starting to get a you know, decent number of people starting to have toxic effects. So this would be a more ideal drug that we'd want to do therapeutic drug monitoring on versus something that was much more wide therapeutic index, right? So looking at how drugs are going to be affecting the patient, we know that basically what the body's doing to the drug, we call that pharmacokinetics, right? So after we give the drug dose, we're going to be looking at things like the bioavailability. We're going to be looking at the volume of distribution. We're going to look at the metabolism and the clearance of the drug, looking at all that variability to figure out, you know, are we getting the right concentration at the drug site, right? And then certainly some patients can have a little bit of variability in that pharmacodynamic response, but primarily we're going to be focusing most on that pharmacokinetic variability, because that's the easiest stuff to measure. That's the easiest stuff that we can account for when we're changing our dosing strategies. So what are some sources for variation in response for some of these patients? Certainly things like drug interactions can affect this, other disease states, genetic differences for sure. And you see how all of these factors can affect, going to play a role in pharmacokinetics and for dynamics. And certainly that's going to lead to a lot of variability in that actual drug response. And so one thing that we can do is look at therapeutic drug monitoring to try to adjust the dose as best we can based on the patient's levels. Ideally, what you'd like to do is be as proactive as possible, and based on a patient's, say, genetic profile, or based on their weight, or based on their ethnicity, you can look at certain features and say, well, this is going to be the best drug for you, and this is going to be the best dose for you based on these other factors. Problem is, a lot of that stuff's still in development. A lot of that stuff is very expensive right now, and so this is why we still do things like therapeutic drug monitoring to make sure that we can try to adjust the patient and kind of try to tighten up and get that drug right in that right level where we're going to be able to, you know, treat the disease without having to harm the patient. So it's been around probably since the 1950s, and as time goes on, as it's easier to get drug levels, and as we start to establish what effective ranges are, this becomes more and more useful. And so we realize that even back in the 60s, that probably half the adverse reactions we saw were due to standard doses. You know, you can give a patient and give you all the same dose of a drug, and some of you would have no problems with it whatsoever. Some of you would have no therapeutic effect, and some of you would possibly get toxic. You know, for instance, does anyone know like a common side effect of taking aspirin is, or if you get too much aspirin? You possibly bleeding. You're not so serious as that. So tinnitus is one of the things you worry about, right? So having ringing in the ears or kind of muffled hearing. I was curious if it was tinnitus or tinnitus, but my neighbor is an audiologist, so he says tinnitus. So I said, well, I'm going to trust the expert here. Yeah, it's good to know, right?
We've been saying it wrong this whole time.
I think you guys can say either one. It probably doesn't matter. It's like last year, one of the students was, I said angina. One of the students was like, I've only heard you and the cardiology guy say angina. Everyone else says angina. And I'm like, I'd listen to the cardiology guy. Like, he does it every day, right? Either one are acceptable. It's fine. Anyway, but one of the things you can see is tinnitus, right? So you can have kind of a muffling of the hearing or kind of a ringing in the ears. And so some people get that at regular therapeutic doses. So my old boss, she'd take a dose of aspirin, and sure enough, she'd get ringing in her ears every single time, right? Even though it was a therapeutic dose. So she happened to be more sensitive. And sometimes it can be very difficult trying to pick out who's likely to be that more sensitive kind of patient, right? And so these are the kind of goals here. So we can try to be more proactive and say, well, I know that you have a G6PD deficiency, or I know that you have this particular ethnic background. You're more likely to have this particular kind of disease state, or this genetic difference that makes you more prone to certain side effects, and things like that. So we can try to better fit, like, okay, who's the best type of patient to receive this type of therapy. So for instance, like one of the things you'll learn is like in hypertension is that based on if you have a Caucasian patient or African American patient, certain drugs they're going to respond to better, right? Because they have the pathophys of their hypertension is a little different. So I know that if I'm dealing with a Caucasian patient, you're going to get an ACE inhibitor, right? Versus if I'm doing the African American patient, I'm going to start you off on hydrochlorothiazide. You know, so little things like that to try to guide you to picking a drug, so that way I don't have to give you the wrong drug. You come back in 6 weeks and be like, my blood pressure is not any better. Okay, probably because I should have gone with a different strategy in the first place, right? So these are the kind of things we're trying to look for, and this is some of the things that therapeutic drug monitoring can kind of help with. So we'll cover a lot of that more in the actual pharm class. But anyway, so we were looking at this and we said, okay, well, drug concentrations for a certain subset of drugs tend to predict a patient's response and toxicity much better than just based on their standard dose that they're receiving. And so these are the sort of kind of started off the principle of therapeutic drug monitoring, where we started looking at this. And it's been kind of in development ever since. So some of the considerations here, we don't do this for every single drug. You could probably get a level on just about any drug you want. You might have to send it off for like a gas chromatograph or mass spectrometry to check it out, see what the level is, but it's not super useful for many drugs, so we don't do it very often. But for a certain subset of drugs that we do use somewhat frequently, you will find that this is the way to go, right? We're going to do this almost every time. So certain antibiotics we do this for. So you guys ever heard of vancomycin? It's good for gram-positive bacteria. We use that very frequently. That one's we always do therapeutic drug monitoring on, right? Gentamicin or the aminoglycosides, those are common gram-negative antibiotics. Those are ones we do therapeutic drug monitoring on very frequently. So it's a small number of drugs, but for the ones we use it for, we use it consistently, right? And so the question is, like, in a lot of cases, you can look at other features, you can look at other measures to determine whether or not the drug's actually working. So for instance, if I can give you a blood pressure medication and you come back 2 weeks later and your blood pressure's dropped down, I don't need to check the level of the drug. I can tell just how effective it is right now, right? Or if I say, for instance, if I have a patient with asthma and they're having an acute asthma attack and I give them albuterol and I listen to their chest and all of a sudden they sound clear. Guess what? The drug worked. I don't need to do a level on that drug to figure out if it works or not, right? So you can do that with serum cholesterol. You can do that with their blood pressure, their weight, all kinds of different things, right? So we don't need to measure those levels of drugs because it's not super useful to us. We can look at what the effects of the drug are. On the other hand, there's certain other measures that you can use for different drugs, so you may not look specifically at the level of the drug, but you may be looking at kind of the other effects you may not be able to see or measure in a patient just by doing a physical exam or doing their vitals, but by doing other laboratory tests. So for instance, warfarin, you guys know what that does? What does it do? Thins the blood, right? So it's an anticoagulant, helps to thin the blood, keep us from clotting off. And so instead of measuring warfarin levels, which we found not to be super useful in guiding how well anticoagulated you can be, well, let's just measure the blood. Let's see how well that blood is actually clotting. So we can use a test called PT-INR. You guys heard of that one? Yeah, so it's one measure, just one of the many measures of how well blood can clot, and so we measure that. And so I can, based on certain ranges, I can look at a patient, I can test their blood and say, okay, your INR is 2.5, perfect range, right? Or if it comes back and it's 4, and I say that's too high, let's change your dose, right? If it's too low, okay, we're going to up your dose. So those are all kind of things we can do based on other measures rather than just measuring the blood level of the drug. Certain assumptions we should be making with therapeutic drug monitoring. One, that measuring the drug concentration gives us an opportunity to adjust that dose for the patient's variability and also individualize the dose essentially. So for instance, if their drug only comes in one way and we can't really change that, then it's not going to be super useful to us, right? We need to have control over how often we give the drug and what the dose is going to be. We need to find that the concentration of the drug is going to be a better predictor of the response than just the dose that we're giving. Okay, so for instance, when you're looking at a patient who's got a bacterial infection, is it easy to tell how many of the bacteria are killing? Not really, right? There's certain things you can look at. You can look at their white count, if it's going down, you can look at their fever, but some of those things take time to really develop. I need to know sooner if I'm actually killing out those bacteria. And so by looking at the drug concentration of those antibiotics, I might be able to get a better sense of that. So that's one thing I want to make sure is a true assumption. And then the other thing is there should be a relationship between drug response and the actual levels that we're getting. So again, there should correlate with one another. If I'm the level's too low and I up the dose, the effect should go higher, right? So there should be a proportional kind of relationship there. So again, looking at things that the clinician controls versus things that we do not control. So for instance, looking at the total exposure to a drug, the bioavailability. Can I affect the bioavailability in a patient? No, I might be able to do something like, if I know they're not absorbing from the gut, I can give them something IV. That may be one thing, but in general, you really don't have a whole lot of control over that. Can you change how well the patient's going to clear the drug? Not unless I'm putting them on dialysis and the drug happens to be pulled off, right? That's not a super easy thing for us to do. What I can control though, how big of a dose I'm giving, and then how often I'm going to be giving it. So these are the things we're going to focus on, and often what we're changing when we have a patient who has a level is too low or too high, we can affect these things to try to get it back in range. So the therapeutic range is not absolute. Basically, we do this based off population studies, right? We study a group of patients and we say, okay, we gave this many patients this drug, these are the levels we got, and these are the effects that we saw. The thing you have to remember is, looking at a population, say 50 patients, can you apply that to every single patient in the US or in the world? Maybe, maybe not, right? We don't know in a lot of cases. It's a question of how generalizable that information is. So for instance, if I did a study and only looked at 50, 60-year-old white men, does that apply necessarily to young females? There may be some things that correlate, maybe some things that don't, and that's the thing you have to look at. And a lot of these therapeutic ranges, they're done back in the 50s, the 60s, the 70s, and a lot of times you find the studies, and they're like, yeah, we did this in 30 people. It's like, well, that's kind of odd that we're making all these, clinical decisions based off of, 40-year-old data and only 30 people. But again, a lot of the times we haven't done any updated studies since then. It's kind of one of the problems of medical literature. But anywho. But the thing is it's based on concepts of probabilities. And so if a patient is within this range, chances are that they should be therapeutic, they should not be toxic. Okay. Now, do patients fall outside of that? Absolutely, 100%, right? All patients are snowflakes, essentially. They're all going to be a little different to the effect that somebody can be above the therapeutic range. Does that mean they're going to absolutely be toxic? Not necessarily. They might not have any side effects from that, right? If the level's too low, they're a little bit below the range. Are they absolutely going to have no clinical effect? Not necessarily, right? So this is why the number one thing I want you guys to know is you treat the patient, not the number, right? So because the number comes back weird or different or not what you expected, and the patient's doing okay, you may not have to do anything with it, right? So always, always, always look at the patient, take the whole clinical scenario into consideration before you decide to change anything, right? So anyway, so that's a big takeaway from that. It's like the thing they say, don't just do something, stand there, right? Oftentimes in medicine, that's usually the best thing. Is just don't do anything, just see how it goes, right? So anyway, so looking at those therapeutic ranges and the additional considerations you want to make based off of that, the range, again, usually going to be characterized in a small population, as I already mentioned, and again, it's very difficult sometimes to ascertain that validity of those published ranges. So again, the rigor to which medical literature may have been subjected to back in the 60s may not be the same as it is today, and so a study I could have done back in the 60s may not have been able to be reproduced today. I may not be able to ever really determine how valid that information is, but in a lot of cases, you're going to find there's lots of medical dogma that we use from decades old that we still just say, well, this is the way it is, and no one's ever really gone back and double checked the word, right? So unfortunately, that's kind of one of the caveats of medicine, is that we do a lot of things, we don't really know why we're doing it. But anyway. So biggest thing we should do is look at the concentration that we're going to be targeting. Note that typically you don't necessarily shoot for a range, even though a range will be acceptable. What I mean by that is, for instance, if I'm dosing an antibiotic like vancomycin, I'm going to be shooting for a trough. And typically you want to decide if you're looking for peaks or troughs, whatever you're looking for. And so I want to trough between 10 and 15. Okay. When I'm deciding how to dose that patient, I'm going to try to shoot for somewhere in the middle. So I'm going to say, well, let me shoot for a dose or a level of 12.5, right there in the middle. And I can choose my dose that I'm going to give. I can choose the frequency that I'm going to give it and try to get that range. Now, if the patient comes back and they're 11, great. If they come back and they're 14.5, great. If they come back way too high than that, they come back 20, then I know something's gone wrong and I need to change something. But generally, you're going to be shooting right from the middle of those ranges, whatever you're picking for. And then, yes, ma'am?
Why would you want a trough instead of a peak?
It's a good question.
I came up with that.
Yeah, fantastic. Do you have an answer? So it kind of goes back to what we were talking about with certain antibiotics in particular. You want to make sure that there's a what we call minimum inhibitory concentration. Have you guys covered any micro stuff yet? So minimum inhibitory concentration is the concentration of a drug you must achieve in order to make sure that you are inhibiting the bacteria from growing, right? So once you get above that, the bacteria being sufficiently inhibited, they can't grow anymore. Right. So for certain antibiotics, especially vancomycin, this is one of those ones where I want to make sure I don't get the trough too low. If it gets too low, I'm dipping down below that MIC. Guess what? Bacteria start to reproduce. I don't want that. So that's why I'm checking the trough, because that way when I dose the trough, once it gets down to its lowest point, I can redose it again and get another peak. And based on that, I can say, well, I know my trough is high enough. I know I'm getting that therapeutic effect. Right. So sometimes you'll be looking for troughs. Some cases you might be looking for peaks. Sometimes you're looking for random levels, and we'll kind of talk about why you would do that in some cases, right?
So you're staying away from bacteria.
Huh?
So you're trying to stay away from bacteria.
You're trying to kill the bacteria. Exactly, right? It's bugging you, it's bugging the patient, kill the bugs, right? There you go. So you always start out assuming, unless you have some other indication, that you assume your patient's acting like the normal population, right? So even though your patient might be a little bit of a snowflake, you're going to assume they're just like all the other snowflakes out there, right? So you assume they're going to have population standard kinetics, like volume of distribution. You're going to assume they're clearing the drug appropriately, unless you have another good indication why they're not. So for instance, if I have a patient I know has renal failure, and I know this drug is eliminated renally, then I'm going to take that into account, right? Otherwise, I'm going to assume they kind of fit the normal population kinetics, okay? And so based on that, that is information you'll find in your drug references. You'll be able to find that in your lexicons, your micromedics, your Hippocrates, all that kind of stuff will have that information. So you'll know what the volume of distribution is. You'll know the half-life. You'll know all that information. And so based on that, we would calculate, based on we know what our range is and we know what our parameters are going to be as far as from the kinetics go for your patient, then we can calculate your dosage regimen. So we'll say that, okay, this patient comes in, they're 60-year-old, coming in with really nasty looking staph infection. I'm worried about MRSA. Let's go ahead and use vancomycin as my antibiotic. And I know their renal function is this. I know they weigh this much. This is the range I'm going to shoot for. You say 10 to 15. This is the dose I'm going to use. Okay. So you guys will get better at that as you go along when you're looking up this stuff, and you'll figure out, okay, here's how I can make those decisions. In a lot of cases, you'll have guidelines that will help you out. You'll have protocols that will help you out in a lot of cases. Sometimes you may just turf it and say like pharmacy to dose, and say you'll forget about it. Like I'm sure the pharmacists are taking care of it. I'm not going to worry about it again, right? You guys will be better than that. You're going to say, no, I'm going to look at this stuff. I'm going to make sure it's right. Pharmacists can help me out, but I want to make sure this stuff is right, right? Because in a lot of cases, especially for some of these kinetics and some of this level monitoring, oftentimes it is pharmacist-led. Like, basically you'll write a consult for vancomycin dosing or gentamicin dosing, and the pharmacist will take care of everything. Basically, they'll order the levels, order the dose, because they've been consulted, and usually working off a protocol, right? Because we can't independently prescribe. In some places, if you're working out in the middle of nowhere, they might not have that available. You might not even have a pharmacist there 24/7. It may be something like the charge nurse in the hospital has the keys to the pharmacy, and that's it, right? Kind of moving away from a lot of that, but in some places, depending on where you're working, there may not be people there. So you guys have to be the expert in those cases. So anyway, so again, looking at how long does it take to get to steady state, do we say? 4 to 5 half-lives, right? Good. So if you know the half-life of the drug, then you know how long it should take you to get to steady state. And so, based on that, what happens if you think, or what do you think would happen if you were to draw a level and it was before the steady state? Think it'd be falsely low, falsely high? Why high? Should be falsely low, if anything, right? Because you remember that kind of dose stacking that happens. So you give a dose and gets. Give a dose, give a dose, give it. So the levels are building up, so eventually you're going to hit that average steady state concentration. And so what you find is if you check it at level too early, before steady state, if it reaches falsely low, and then your inclination is to do what? increase the dose, right? So then at that point, by the time the patient really does get to steady state, you recheck it, and guess what? Level's way too high, right? That's one of the common problems you run into. And one of the things we'll see is like, physician will say, hey, the level's too low. I need to up the dose. And I'm just like, well, you check it before steady state. I know, but the level's too low. I was like, just wait. Give it another dose, check the level again, guess what, comes back normal, right? So that's one of the things you always want to be careful is make sure you're checking at steady state. And so based on the drug, that may be 3 doses you have to give before it gets to steady state, or in some cases maybe a few days, just depending on what's going on. So anyway, so looking at this, one, you can have scenario A where you say, okay, the patient's having adequate response, the patient's at the target concentration, everything looks good, you can continue treatment. On the other hand, though, what happens in a lot of cases that the patient is either clearing the drug differently or their volume of distribution is altered or something, and they'll come back either subtherapeutic, so below the target range, or they'll come back toxic above the therapeutic range. Or in some cases, it may be a patient who's been on a drug for a long period of time, and all of a sudden, for instance, like seizure medications, right? Patients may go a long time without checking levels on their seizure medications. What might be one sign that their levels are too low? They're having a seizure, right? So that could be one of the things that prompts you to actually check a level to be like, okay, what's going on? Are they actually taking the drug that they're supposed to? Whatever. On the flip side of that, you can tell when someone's toxic on their antiepileptics because you usually find them passed out in their seat or something. Or they're very ataxic. They're not walking appropriately or things like that. So sometimes there are things that will happen that will prompt you to get a level, even though the patient might have been therapeutic previously. So just keep that in mind. But at that point, we should be monitoring the dose, the interval, and we'll look at why we do each one of those in those cases. So, reasons that we would do drug concentrations, right? So, one, if this provides additional information to us, in addition to some of the other clinical data, and including the patient's presentation, that will help us to make a decision, right? So, a lot of times, people will order a level for something. I was like, well, what if it comes back too low? Are you going to do anything? No. If it comes back too high, you're going to do anything? No. Then why check it, right? So in a lot of times, you may not need to check a level, right? So you need to have a valid indication to do so that it's going to actually provide some kind of benefit to you. A lot of people just feel like it's, I just want to be sure. That's not usually a good indication to try to spend money on expensive tests and all of that. You usually need a good indication. But again, if the drug levels are going to help us provide a basis for that, to individualize the dose, to make sure that's going to be something specific right to that patient. And then we can also look to see if we've determined any kind of changes in kinetics during treatment. So things like physiologic status. Has that changed since when I first started dosing the drug to now? So for instance, patient undergoes renal failure. That's a big change, right? Or the patient has massive edema, and now their volume distribution has changed. These are all things that may prompt me to get a level. And then if you're looking for certain interactions, whether it be drug, food, herbal interactions, is all maybe things that may lead me to check a level, okay? Another thing, checking for adherence, right? So meaning, is the patient actually taking the drug? And so for instance, I had some, when I was in fellowship, I had a friend who was rotating in the pain clinic. And so the pain clinic, they would do urine drug screens, and they would test for things like hydrocodone, right? Hydrocodone is in Lortab and Norco. And I was like, well, why the heck would you check for that? Like the patient, you prescribed them Lortab. Why would they not come back positive on Lortab? And they're like, why do you think they wouldn't come back positive? So what do you guys think? Yeah, you guys are more world weary than I guess I was at the time. Yeah, so they're like, no, they're going to sell it. So we want to make sure they're actually taking it. And that's part of their agreement, is that if they're going to be prescribed this drug, they need to take it. And if they don't show positive on a random drug screen, then they get kicked out of the program, right? So sometimes you're checking levels to make sure the patients are actually being adherent on something. Or if they're seizing and they're coming in and want to make sure their drug level is appropriate. One of the things that we saw with some patients is, I don't know if I mentioned this story in the peds section, but for the phenytoin suspension, right? Phenytoin is a popular anticonvulsant, and essentially one of the things you have to tell people when they take a suspension is what? You got to shake it up, right? Because with a suspension, what happens to the particles if they sit for too long? Settle down at the bottom. So no one ever told this mom to go ahead and give their kid, or to make sure they shake the bottle up before they gave the suspension. So mom was like, man, it's craziest thing. Like, the kid was seizing all throughout the month, having kind of breakthrough seizures. I was dosing him appropriately, giving him the right amount. Then all of a sudden, at the very end of the month, the kid snowed. He's just completely near comatose, right? And they're like, well, did you shake it up? And sure enough, mom had not been doing that. Check a level sky high, right? Because basically the mom had not been given any drug throughout the month. Then once you get to the bottom, all of a sudden the kid gets all the dose at once, right? So sometimes you check levels because of things like that, to try to make sure that they, even though they may say they're being adherent, make sure that the levels actually make sense based on what you're hearing, right? All right, so other common requests for drug levels, if the toxicity is suspected, if you think there's a lack of therapeutic response, so you're given an antibiotic and the patient doesn't appear to be improving anymore, that might be an indication. Check for adherence. If you're assessing for changes in a dosing regimen, so you change a dose, oftentimes that will be an indication to get another level to see where they're at that point. You see a change in the clinical status of the patient or any kind of potential drug interactions. These are all really good indications to go ahead and get a drug level to figure out what's going on with that drug. So, information you need to interpret serum drug concentrations appropriately. So 1, what was the time the blood sample was taken? A lot of this is dependent on how good is your nursing documentation, right? Nurse is super busy, they're taking care of 5 other patients, they may not have time to draw the level at the right time, or they may not document the right time that they took it. That can all lead to potential error in you making your decisions based on the timing that was documented. You need to know the time the last dose was given. Okay, you need to know what the regimen is. So again, especially if maybe you didn't start the drug on the patient, you need to know get good information to figure out what they're taking and how often. You want to patient demographics, look at their concurrent medications list, because oftentimes you can find drug interactions that will send your level up or down depending on the interaction. You need to know your reason for monitoring, so why do we get this level in the first place? And then looking for that desired kinetic or therapeutic range, right? We need to know what kind of levels we're shooting for, and that can make sense for certain drugs like antibiotics where for instance, vancomycin, if I'm dealing with like a skin infection, it's very easy to get the drug to the site. I may shoot for lower levels, say 10 to 15 mics per ml, versus say meningitis. It can be very difficult to get drugs to the site of infection. Right at that point, where is it at? Meningitis. It's a meninges, so it's in the CNS, and you have the blood-brain barrier to compete with, right? So if I'm shooting for levels for areas where it's harder to get the drug to, I can end up shooting for a higher level. So you need to know what kind of level you're shooting for. So in those cases, I might shoot for 15 to 20 versus 10 to 15, right? So you need to know that kind of information beforehand. So looking at common drug characteristics, so again, in some cases you may find that with some drugs there's no clear observable therapeutic or toxic endpoint. So in a lot of cases, some drugs you may not be able to check a level, and it may not correlate really to anything, either therapeutic or toxic in some cases. We should be assuming that the concentration is going to be a surrogate for the concentration at the site of action. So basically, when I measure the plasma level, you're using that as a surrogate for what the level of the drug is at the actual site. So that's why I know that even though my level of vancomycin is 20 in the blood, I know it's probably not nearly as high as it would be in the CNS because I know it's harder to penetrate. But based on that level, I can say, yes, this is still sufficient for that to correlate right to I'm going to be killing all this bacteria. Okay. And again, looking at that narrow therapeutic range, usually we're going to be doing this for drugs that have variable pharmacokinetics, right? So either things like dehydration can change the volume of distribution, or renal function can change how well it's cleared. Those are kind of things, the kind of drugs we're going to be doing this for very frequently. So again, with these drugs we're going to do TDM for, risk should be associated with both the toxicity, so if the level gets too high, there's problems with that, or in the lack of response as far as that efficacy goes. So again, if it's one of those drugs where it doesn't matter if I give you a 2 or 3 or 4-fold overdose, you're never going to get toxic. It's such a high therapeutic index. We probably don't need to do levels on that, right? Because it doesn't really matter. We can just up your dose if you don't seem to be getting really therapeutic. These are really only for things with narrow therapeutic indexes. I think we should hope for a stable pharmacologic effect. So based on the level we're seeing, that should equate to a stable effect. You really shouldn't have a lot of variability in that, right? So that's a common characteristic we're looking for these drugs we do TDM for. So also, when we do our drug assays, we need to make sure that they're accurate, they're precise. We want to make sure that the levels we're getting back are going to be true, and they need to be specific. Sometimes you'll find certain assays will actually have cross-reactants with other things, and so a good example of that is a drug called digoxin. You guys familiar with digoxin? What do we use it for? We use it for arrhythmias, actually. So it's an antiarrhythmic drug. And sometimes patients with really critical illness, like they're very, very sick, they can actually have cross-reactants that the body produces naturally that will trip that assay and actually show it would be too high in some cases. So you want to make sure that the test you're using is very specific. There needs to be a reasonable turnaround. So in a lot of cases, say for instance, really deadly poisons like cyanide, right? Cyanide kills you very, very quickly in a lot of cases, especially if you're like in a house fire or something. It can be hours. I can get a level for cyanide to decide whether I want to treat or not. But it takes 2 or 3 days. So by the time I get that level back, my patient's either dead or alive. Not super useful, right? A lot of times I have to base my decision to treat on other things, like, okay, they have soot in the nose, or their lactic acid is through the roof, or whatever I'm basing it on. So you need to look for things that have reasonable turnaround times. Hopefully it's relatively inexpensive. Usually things you have to send off for, things you don't routinely check levels on, usually end up being a lot more expensive. So stuff you can do in-house is usually a lot more reasonable. So commonly monitored drugs, we mentioned anti-infectives quite frequently. So we have vancomycin. This is really good for gram-positive infections, especially MRSA, the dreaded methicillin-resistant Staph aureus. And then we have aminoglycosides, so things like gentamicin, tobramycin. We do this for gram-negative infections, right? So this is very good broad-spectrum gram-negative killers. These are very common ones. This is probably the most frequent ones we do in the hospital, right? Especially like ICU patients and things like that. Certain cardiovascular drugs we'll do levels for, like digoxin I mentioned. A lot of anti-epileptics, because in a lot of cases you may not know just how whether or not the patient is actually therapeutic. Because with seizures, the thing is, like, you can go a whole month and you don't have a seizure. So it's like, well, because the drug was working, or because you just wouldn't have had a seizure regardless, right? A lot of times it's hard to tell that. So that's why we can look for levels to see, well, you're in the therapeutic range, you're not having seizures, and we're assuming you're therapeutic, right? That's one of the things you're looking for. Phenytoin is a common one, carbamazepine, valproic acid. We'll talk all about these when we get to the anti-epileptic section in Pharm. And then certain immunosuppressives. So what do we use these for, do you think? Yeah, autoimmune disease and also transplants. Those are the two big things we'll use immunosuppressants for. So things like if we're trying to prevent rejection of an organ, right? So you don't necessarily want to wait till that patient's rejecting the organ to check to see if the level's good on the drug, right? You want to be able to do that beforehand. So that's why one of those things you don't. That's why you can't tell how effective the drug's necessarily being unless you look at the level. Okay. So anyway, limitations with TDM, cost. It can be pretty expensive if you don't do it correctly. Drugs have a wide therapeutic range, may not be super useful to get levels on, so it could, that would kind of rule out a drug from being very effective for doing this. Or if there's not really concentration in a response relationship has not been established. I'll have a lot of patients who come in seizing to the ER, and they'll be on a drug that we can't get levels for. We can get levels, but there's no established range. And the doctor will be like, well, go ahead and get a level. And it'll come back in like a week. And I'm just like, well, there's no range for it. What are you going to do if the level's this? And they're like, I don't know, I'll check, I'll figure it out then. Okay, well, that's not super useful, right? So again, this can be incurring extra costs. So you need to make sure that relationship's there. Looking for reference data that can kind of back you up to say, well, this is the range we should shoot for. And then again, if you have other direct response measures, like follow those first, right? So if you're looking at blood pressure medication, look at the blood pressure first, right? You don't have to get levels for that kind of thing. Okay, so inappropriate uses. If you're getting either levels routinely, or you're saying, I'm going to check a level every day. Well, if nothing's changed with the patient, why would you assume the level changes? It shouldn't. You can't just do it just to be a safety blanket. Like some people like to do that, just check levels just because it makes them feel better. Not a good indication, right? Because if you had to write indications for everything you did on the chart and you said, because this makes me feel better, insurance probably wouldn't want to pay for that, right? So you need to have a good indication. So either doing it too often or just doing it routinely without a true indication. You know, in some cases, do you need to get concentrations for a patient that's responding appropriately? Maybe not. You know, in some cases, you may find the patient's doing well, if they're not having any toxicities. You know, do I need to go ahead and check another level? You know, if it comes back a little high, a little low, am I going to do anything with it? Probably not. You know, if the patient looks good, you may not need to do anything. And then looking at you know, obtaining these in patients when there's no apparent change in their specific kinetics, you know, this kind of goes along with the kind of routine measurements where it's like if there's no big change, no indication to do it, why do it in the first place? And then the other big thing, if the samples are taken incorrect times, so I can't tell you how many times we'll do a level. Say for vancomycin, I'm shooting for say a level of 10 to 15, and the level comes back and it's like 35 or 40, and so your first thing would assume patient's getting way too much, right? They're not clearing it or something. But then I look at the chart, and turns out that they checked the level 5 minutes after they started giving the dose. Well, yeah, of course the level's going to be too high. It's a peak level I'm measuring at that point, right? So you have to be able to look back at that sort of thing and figure out, like, okay, well, does this make sense based on what the timing is? And a lot of times you'll find that no, it was probably given, or the level is drawn incorrectly, right, in a lot of cases. But the benefits of doing this, the things we've been able to show, is that we can reduce the number of patients encountering toxicity, which is a good thing. It incurs, you know, less cost by treating side effects. You know, this is going to be for patients who have more time in the therapeutic range, which hopefully presumes they'll have better therapeutic outcomes, right? It's kind of a big assumption there, but let's assume that. And then, of course, this is compared to those patients who are managed without TDM. We're just saying, okay, you weigh this much, we're going to give you this much drug, and that's it, call it a day, right? So TDM has shown to been effective in those kind of comparisons. So other benefits, we can see improved effectiveness, hopefully reduce toxicity, hopefully we can reduce the length of stay, so especially if we can clear an infection more quickly, that can be a good thing. And then we'll have a lot more rational use of drug concentration. So instead of just measuring a level and not really having any idea what to do with it, we have better ways to deal with those levels. And it's been proven to be cost effective. So by getting shorter lengths of stay, you can get more patients through the hospital, you can make more money, right? So these are kind of things that they look for, kind of programs they want to pursue, are things that are going to be cost effective like this, right? Like you imagine, like, the cost it would be if you dosed a patient, you caused renal failure because you weren't checking the levels appropriately. Like that's pretty expensive, right? And a patient, getting put on dialysis, something like that, like it's costly, right? So you want to avoid that sort of thing. But again, levels are drugs we've been able to show benefits with, things like the aminoglycosides for sure. Drugs like we don't really use theophylline too much anymore, but it's an old school asthma medication. Digoxin, lithium, these are all things we'll do routine measurements on because we know them to be kind of a cost-effective sort of measure. Okay. So the steps in doing therapeutic drug monitoring. First off, we want to figure out what our indication is going to be. Again, if it's either lack of response or it's a side effect or whatever it happens to be. We want to make sure we're looking at the right blood sample collection. Okay. You guys covered any like clin lab stuff yet? Okay, so you'll learn that there's all kinds of different tubes that are involved with running lab tests, right? So there's green tops, there's red tops, there's tiger tops, there's all kinds of different tops, right? If you put a gun to my head and said, pick the right one for this drug, I wouldn't know. But nursing knows that, and that's the important thing. So you need to make sure, one, they're measuring the level at the right time, and they're using the right kind of collection tube. So for instance, some of the tubes come lithiated, meaning they, for whatever reason, in order to run that particular test, whatever they run, they have to include lithium on the top. Well, guess what happens if you're checking a lithium level and you put it into that tube? Comes back high, right? So those are kind of things you can look for. Be like, well, the patient's totally fine, but the level came back, 4 times as high as it should be. Okay, well, what kind of tube do you use, right? That could be one thing. If you imagine if you're looking at a heparinated tube, because a heparinated tube would do what to your blood? Keeps it from clotting, right? So if I'm checking my coags, if I'm checking my PTINR or my APTT, it might come back odd, right? Because it's already heparinated. So those are the kind of things you need to be considerate of. Again, you're looking at the laboratory measurements, and basically the communication results is really important. So we ran into this very frequently at the poison centers, because at the Jacksonville Poison Center, we basically covered all of North Central Florida into the Panhandle. And so we're dealing with a lot of different hospitals that all have the potential to report things back differently. So a good example of this was with an aspirin overdose. Normal aspirin therapeutic levels say 15 to 30, right? If you start to get up to like 45, 50, like you're starting to get toxic. If you get up to like 100, that's when you're like at risk for seizures and death and all kinds of bad things. So I see 100, I get really worried about that patient, right? And so that's usually in milligrams per deciliter. Okay, so all right. So I had a patient who was overdosing on aspirin. The lab called back and they said this patient's level is 400, and the nurse just said it like, it's 400. And I was like, is that right? And they're like, I think the lab did it right. And I was like, what are the units on that? And they said micrograms per ml. And I said, that makes more sense. Because when you actually do the conversion from 400 mics to per ml, it comes back at 40 milligrams per deciliter. That's a lot safer, right? So it's not nearly as close to that really toxic range as I expected. So be careful with the levels. Make sure the units are appropriate, or they're at least what you're expecting it to be, because that can make all the difference. So then once we have our levels back, we have good communication of those results. We want to figure out, okay, what is the next step of management? Should we change the level? Should we change the dose? What should we, or change the frequency? We have to look at the patient's clinical picture as well. A lot of times, if the level comes back a little too low, but the patient's improving clinically, I may not want to do anything with that level, right? So, and then we'll optimize the drug treatment. Usually, either modify the dose or the interval, or both in some cases, and then you rinse and repeat. So, basically, you'll change them. You'll check another level once you get to steady state, figure out where we're at that point, and then make any other changes you need to do. You basically kind of do that until the patient's therapeutic. Just considering pharmacogenetics, you guys remember what pharmacogenetics is? Yeah, basically using the genetic background of the patient, those kind of polymorphisms they have, in order to guide you in choosing what kind of drugs you should use or what kind of dose you should use. And so you find that therapeutic drug monitoring is very kind of a reactive process, where we get a level back, make a change, wait for another level to come back, make a change, and it's kind of reactive. The ideal thing we would like to do is be proactive and based on things like your pharmacogenetics. If I know that you come back and you have a 2C9 polymorphism to where you don't metabolize drugs very well, it's the CYP enzyme 2C9, then I know that, okay, maybe I should change this dose to a lower dose or use a different drug altogether. That can be a lot more proactive. You're going to find this is becoming more frequently used, especially with certain common kind of high impact kind of mutations. So certain CYP enzyme mutations we may be checking for, certain ones like G6PD deficiencies, things like that we can check for, certain enzymes and whatnot. And so that can lead us to choosing one drug versus another. Some drugs you have to do a genetic test on before you even give it to make sure they don't have problems with it. So there's certain drugs where you may be more likely to have anaphylaxis based on certain mutations. Okay, so that's going to be the ideal thing we like to have, and that's probably years in the future. Because ideally, you start out with a kind of a homogeneous group of patients. You're going to find that majority of them probably predict pretty well at a given dose. You're going to find some that have either no or poor response, or those are going to have more likely toxicity. So I'd like to be able to pick these people out of the crowd beforehand, so make sure I can dose them more proactively and prevent any toxicities or have better efficacy. So, and nowadays what it's kind of like now is that you kind of go from like drug A, okay, that didn't really work for the patient. Let's try drug B, see how that works. Okay, that didn't really, let's try D. And that didn't work either, so let's go to C. Well, maybe let's try drug D again. Let's try a different dose. That worked better. Ideally, what you'd like to do is be able to do a test, check for different polymorphisms, and say, okay, well, I know drug D is definitely going to be the right one. So hopefully we're going to get to a better point with that, with more drugs as we move forward. Okay, any questions from the first half? All right, so let's use an example. Let's try a case out. So digoxin, I mentioned it's an antiarrhythmic. Let's say a patient has been on the same dose of digoxin for about 15 days. We've seen back in the clinic, and they're found to do well clinically, so they don't seem to have any complaints or anything. Digoxin plasma concentration is drawn in the morning of her visit and comes back at 3.4 nanograms per ml. And we know our therapeutic range is 0.5 to 2 nanograms per ml. So based on that, what can you tell? It's too darn high. Yep, okay. So what are some possible explanations, do you think, for this too high level? You want to know the times you took it? Okay. So we need to know, like, are we checking at a peak level? Are we looking at a trough level? Are we checking a random level? Does it really matter? Those are good to know. Times you took it, we don't know that. What are some other things that she could have done to cause too high level?
Mistook it.
Mistook it, so she might have done what?
Taken it twice.
Yeah, maybe she took it twice. Yeah, maybe she misunderstood the dosing and maybe taking twice a day when you're only supposed to take it once a day. Like, lots of different things could have happened here. So these are all good questions. Yourself. And so first question, when was the dose taken? When was the blood drawn? So you can coordinate when the times are being done for that stuff. What is her dosing regimen? Have there been changes recently that maybe she was not aware of, or maybe she was not communicated to her, or maybe she heard something wrong? So figure out what she is taking the dose, how she's taking it. And then find out if they're having any side effects. So for instance, you'll learn what the specific side effects for different drugs are, but for instance with digoxin, you would expect to see things like haloing around the lights, like so basically kind of halos, and they have this yellowing, kind of greening of the vision, called it xanthopsia, vomiting, etc. So if you saw any of those things, then you say, well, actually, she may not realize she's having these side effects, but maybe she's actually toxic from digoxin. These are kind of questions you're going to ask to see if she's really having any problems or not with it. So then, remembering that the bioavailability, or our average steady state is based on the bioavailability times the dose divided by clearance, and also the dosing interval, we can look to start to see, like, well, what could be going on here? So one question is, is the patient absorbing more than average? Say she's taking oral digoxin. Is there any chance for this, you think? Probably not. There are some cases where you may see this, like for instance, some drugs are better absorbed with like fatty meals on board, and so sometimes they'll either tell you to take it with food, without food. So that could be one thing, but probably is not likely to be occurring in this case. Is the patient taking more dose than prescribed? She's taking more than she's supposed to. That's a question you can kind of rule out based on what they're telling you. She may be old enough to where she's not really sure, she can't really remember what she took. That could certainly be a big room for error, right? So if they have caregivers, try to interview them if you can to figure out what's actually going on, how they're actually taking the doses. Then the clearance. So then you want to see, well, okay, maybe the patient isn't taking too much. What are some other reasons why she could have too high a level? The next thing could be clearance. So if she's not clearing the drugs like she should, say for instance her renal function took a hit recently, that could be something that can happen, right? So just having an acute change in renal function can certainly lead to super therapeutic levels. That could be one thing we want to worry about. And then the dosing interval, is she taking it too frequently, right? If she's taking it too infrequently, she's taking it less often than she should, then our level should be low, right, in most cases. So, and this probably isn't the case here, but maybe she's taking it too frequently. So you can kind of narrow down, see what the problems are, and see what the potential errors could be that's going on here. So, and then you look at the level itself. Is there an error that's happened here? Did they run the assay incorrectly? Sometimes we'll have certain labs where the tests have to be kept on ice for a certain period of time. If they're not kept on ice appropriately, they go bad, essentially, and the results are inaccurate. Or, for instance, like potassium levels. Anytime you check blood for potassium, the potassium comes back super high. One of the things you worry about is anyone know? Could be kidney function, but the kind of the lab error thing could be hemolysis. So if you actually have like a poor stick, or if the blood sample is it's been especially turbulent, sometimes you see hemolysis of the red blood cells, and that can spill out potassium. So little things like that, you'll kind of learn, see like, well, what are the common reasons why this may not be accurate? So we'll assume that the lab is good. We'll assume that she went to Quest, and Quest has got a pretty good track record. We'll assume that everything is okay from that standpoint. But you can worry about things like interfering drug substances. There are certain plants that actually contain digoxin-like molecules, so for instance, if she was maybe taking something that cross-reacted there, that could be a reason for a falsely high level. So those are also questions you want to find out. Don't just ask what drugs do you take, also ask what other things. Do you take dietary supplements? Do you take herbal supplements? They might be more likely to be more open with you with that sort of thing. So now what? Now what do you want to do? Well, let's confirm the sample timing, make sure all the timing is appropriate, and we see that everything is what we think it is. Look for the patient adherence. So she's like, yeah, taking everything like I'm supposed to, told me to take one time a day, I'm taking it like I should. So you say, okay. And then you're assessing for any of those other substances, and they're like, no, not taking any other kind of substances there. So the question is, should I repeat the sample? What do you think I should do? You're going to repeat it? Okay. You're always probably safe to repeat. The question is, though, that if it came back just as high, then that gives you an indication that, yeah, probably the level is too high, right? Or of course, if it comes back normal at that point, then you got to figure out, like, well, was the first one wrong? Is this one wrong? Like, sometimes you have to kind of ask that question as well, so you kind of get a feel for that sort of thing. But again, you can look at the clearance. So again, in addition to looking at just what their level is, what else could I check for this patient, organ-wise? I check the creatinine, right? So if all of a sudden, like, her baseline creatinine is 0.6 and now it comes back 1.2, that could be pretty indicative of a change in renal function, right? So that could be one thing I can actually assess over there. So you're not just looking at the drug level, but also looking at kind of associated labs as well. Okay. So again, is this an appropriate use of therapeutic drug monitoring? Do we have an adequate indication? Do we want to make sure we have appropriate timing of the levels, and then we want to make sure we have a rational interpretation of that level now that it's come back abnormal? Looking at the indication for digoxin, this does fit the criteria because one, it has, we can either look for things like suspected toxicity, which this patient isn't having, or, because it is a new treatment, because she just started, this is one indication we can do it. And then also, you just have like a high-risk patient or someone who's kind of impaired clearance of a drug. That could be another reason to make sure they don't get potentially too high on that particular drug level to make them predisposed to the kind of bad outcomes. So if I have a patient who I know has a history of arrhythmia and I know they're more prone, I know they have poor cardiovascular status, that would be a high-risk patient to me for taking digoxin. I'd be more likely to check those levels a little bit more carefully. So other things we can be looking for, maybe there's a drug interaction, we want to see if it's having an effect on our level. If we think there's a suspected overdose, either intentional or unintentionally, so she accidentally took too much on accident. And then if we expect any change in kinetics. And then again, another thing is you may check a level to see if this is a drug you want to continue or not. So for instance, if they've been taking it for a while, they're not really noticing any benefits, you check a level and it's like, normal to high, then you may say, well, maybe this patient just doesn't respond very well to this drug. It may lead you to decide to try another drug altogether. So that's a kind of less common way, a reason why we do levels. So other effects to be aware of is the level of steady state. Well, this one already came back high, so we can probably assume it's probably a steady state. But you can look to see, what the half-life of digoxin is, and now she's been on for 15 days. Should she be a half-life, or should she be at steady state or not? And you can make that assessment. Again, look for the sample timing, look for adherence, make sure they're taking it like they should be. Looking at the timing of the dose in conjunction with the sample timing, make sure those are done appropriately. So for instance, if you check a trough level after they just gave the dose, obviously it's going to come back incorrect, right? Things you want to look for, and then just intrapatient variability. Just know that some patients are going to clear drugs better than others, some are going to be more sensitive to the effects. So you have to take all those things into account. So some of the factors you can look into to the drug administration or the blood sampling logistics. So the logistics can be really important here. So one thing is, was the wrong dose given, or maybe the infusion rate was wrong. So you run into this more in the hospital standpoint, where perhaps the wrong dose was administered, it was either made incorrectly or was diluted incorrectly, or perhaps the drug was given over too long a period of time or too short a period of time. So those are kind of things you want to find out. Sometimes we'll find that levels come back low, and we come back and say like, oh, and the nurse says, oh, well, I had to hold the dose because the patient was down an MRI, and so they end up missing their dose. And they said, well, I just went ahead and gave the next one. Okay, that might be one reason why your levels are too low, and those are things you can look at on the chart. You can have the dose given at the wrong time, but the blood drawn at the correct time, which again, hopefully your documentation is correct, otherwise you can't really make heads or tails of this. Or if the dose was given at the correct time, but the blood was drawn incorrectly, either too early or too late, that can all lead you to making some poor assumptions unless the timing is documented correctly. Other things you can look at, so looking at the actual blood sampling logistics, was the sample taken through the administration line? So for instance, if I just ran vancomycin through an IV line and then I pull the blood off of that line, probably going to be high, right? So that's one of the things we run into. They'll say like, oh, the level is 50, and I'm just like, well, was it drawn to the same line that the drug infused through? Yeah, okay, that explains it, got it. Sometimes was the sample taken from the wrong patient? Hopefully this is being averted with things like barcode scanning of patients and whatnot, but you'd be surprised by just how frequently it is that patients either have very similar names together. In any given ER, you can find, 3 different Smiths and 4 Rodriguez's and, 10 some other name, right? So you have a lot of people that end up having very similar last names. That could be one reason for pulling the wrong patient. Patients move rooms all the time. That can be another indication. Think about dealing with, like, if you're in the NICU, right? It's a neonatal intensive care unit. You have twins, baby A and baby B. They probably look just alike, right? Like my sister had twins 4 or 5 months ago, and I still can't tell the difference between them, and they're not identical. So again, that's why things like barcode scanning can be very important. It can kind of help you avoid situations like that. We mentioned the sample handling issues. So if something needs to be on ice, make sure that was done appropriately. If it's in the wrong type of tube, all those can have effects on changing your levels. So these are all things you want to investigate when the level comes back and it doesn't really make sense for you. Other factors you want to look at, so maybe the patient fell outside of the population kinetics. Maybe there's something with them where their volume distribution is very different than what you would expect from the population, that they're really dehydrated, or if they have a lot of edema, or perhaps their kidney function is different, or liver function. And then if the levels are drawn prior to steady state, you should expect it to be too low or too high. Too low if it's before steady state, right? Because again, you haven't had enough time for those doses to kind of stack up on one another. And then another thing you'd want to be curious about is certain drugs, they actually take time to distribute out into the tissues. And so we call this a distribution phase. So for certain things, like lithiums, drugs like that, it takes time for them to go from the blood and partition out to the tissue, sometimes like 6 hours or so for that to occur. And so sometimes that can be an indication or a reason why the level doesn't make sense if you drew it too early. So if you draw the level within that 6-hour period, it would look falsely high. If you check it again later, it would look totally normal, right? So that could be one thing you want to consider. So other things was the right drug assay. We'll have levels that come back and it looks like it's negative, and we're like, well, did they even test for the right drug? That could be one reason why something can come back erroneously. We mentioned interference with endogenous substances. I mentioned critically ill patients can have cross-reactants with digoxins. That can be one problem you run into, or just improper storage of the sample and just technical errors of the assay. So sometimes we'll find that you'll notice it like in a hospital too. Like you'll do like a you'd be running all your patients' vancomycin levels, and you're like, everyone seems to be too high, everyone seems to be too low. Like, it can't be everyone is being dosed incorrectly, and it turns out like the lab was doing something goofy, and then that was affecting all your samples, right? So sometimes you can always go back to the lab and be like, hey, can you just like double run this for me? Usually they'll have some sample left over, and then you can just run the test again to try to make sure that it's actually accurate. So looking back at the digoxin case, digoxin happens to be another one of these drugs that actually has a 6 to 8 hour distribution phase. It takes time for the drug to get distributed out to the tissues. And so what you actually found is that if you draw it too early, those levels will look falsely elevated. So the patient, turns out, she had taken the dose 2 hours before actually taking the sample. So again, because it's still in that distribution phase, it would look like it's falsely high because all that drug is still in the blood. They did a repeat 6 hours later, comes back at 1.1, it's within range, and guess what? We don't have to do anything, right? Now, for instance, if you said you rechecked that again and it came back and the patient's looking good, cardiac function seems to be good, but it's a little bit below the range, would you do anything at that point? No, if it's a little bit above the range, yeah, again, don't just do something, stand there, right? Sometimes you just don't want to do anything to the patient, just kind of let it slide if they look like they're doing well and the levels are just slightly out of range. So So in summary, that's therapeutic drug monitoring. It's going to be using serum levels to try to guide us to shooting for a therapeutic range to make sure we're getting the patient therapeutic without making them toxic. And so it's important to understand those merits, those limitations, to know, again, don't just check a level because it makes you feel better. Have an indication in mind and say, why am I checking this, and what am I going to do about that level when it comes back? You know, kind of on a slightly unrelated topic, things like urine drug screens, right? So when you go to a patient who has overdosed on drugs, right? So they overdose on something, you don't know what it is, and they come in and they're comatose. You know, they're barely breathing. We're having to intubate them to breathe for them. The doc's like, I'm going to order a urine drug screen. I'm like, okay, well, what's that going to tell you? They're like, well, it'll tell me if they're on certain drugs. And there's a certain panel to always test for. And like one of the things, like, you know, patients will come back and they're positive for cocaine. And like, what did you expect? Like, you know, guys, I'm sure no one has done cocaine, I hope, but I'm sure you've at least familiar with what someone might look like if they're on cocaine. What would you expect? Wide awake, they'd be feeling really good, they'd be bouncing around, they're hypertensive, tachycardic, they're sweating, right? A patient who's comatose, I'm having to breathe for them with an ET tube. Does that look like cocaine patient? No, so it doesn't matter if they come back positive on your drug screen, right? So it's one of those things where like if the levels or the results come back and they don't change any of your management, just don't do it in the first place. It just provides you with kind of excess information that is erroneous or is maybe true, but it could be completely unrelated to what's going on, right? So I'll harp on about urine drug screens later on if we ever talk about tox stuff, but beyond that, just be aware that you need to have a good indication and know why you're doing it and what you're going to do with that level when it comes back. Okay, so any questions on that section? All right.